because I'm an artist and I have art students and I like to put music on in the background. I keep having to switch the music. It's just so irritating to me. So to find, I'm sort of down to Baroque music. I can tolerate the most Baroque, and maybe some jazz occasionally, but there's always a moment when I'm just really, it tenses me up so bad. I don't know, what is that?
Like, I mean,
neurological condition.
I mean, the two styles of music that you described are fairly simple. They're simple melodically, and they're not super overstimulating. Like Baroque music is very predictable in structure and form. And I mean, the music that is overstimulating or overwhelming to you, what is just all other styles?
Every other style, I can't find any. I used to like folk music, somewhat tolerable. Put some Joe Baez on or something. But I don't know. Maybe I stopped liking music at that period, sometime back in the 70s and 80s or something, and I have this gap. I don't know what it is, but anyway, I do like to put on music. It does help the students when they're drawing and painting. It helps everybody concentrate, just, calm down. But it doesn't help me. I'm like ready to claw out.
Yeah, I mean, for you, that's definitely a situation of knowing your own preference too, and
just keep looking.
Yeah, and choosing music that you're playing as ambient music, just make sure it's music that works for you, that's not going to set you off or be overstimulating or overwhelming for you.
Okay, that's probably what. Thanks.
I think the issue is you're listening to Baroque music.
Probably.
Anything else?
Mostly for music therapy and psychology is they're a good way to change your relationship with pain on either of those approaches. Or a good resource.
I think when we experience pain as such an integral part of us, if we're able to look at it as a separate piece of us where I am experiencing pain versus I am this pain, and we can learn the relationship about that in it's very minute, but I think in a very different way. Whoa, sorry. If we can learn to at least cognitively think about it in a different fashion where it's almost separate from us as a person, it's a part of us, but observing it almost like I was describing with the mindfulness where we're an active observer of that pain, and that pain is not overwhelming our lives in such a way, but it is there, but we can manage it and do something about it, and having some sort of control in that sense, is important. And it's, again, a very minute way of thinking and reframing it, but that can sometimes be helpful.
And I can say, just from a personal experience, it's still an ongoing challenge for me, just, on a lived experience level. I mean, every day some days are better than others, and some days are really horrible. But I know, building on that technique, just sometimes what I will do for myself is I will do a meditation, or I'll just put on music that is relaxing in some way to me, and I will observe the pain and think of it as like at an awareness level. I have one particular imagery script that I've used before for both myself and patients, where you sort of evaluate it. You are looking at it from an external observer point of view, so that it is separate from yourself and your identity, and then to sort of move through it and do something with it. But just at a personal level, it sucks.
Yeah, that sort of thing from people going through chronic pain before is giving it a texture, giving it and being able to describe it in a different color, flavor, a way, and then it morphs. This chronic pain morphs.
I've had patients where they draw a picture of their pain, and so again, they can use colors, and it's so interesting, and it shifts too, so it's not always the same. And so when somebody will come in, we sometimes will start with that, and every session it could look very different from the session before, and depending upon where in their body or what the pain feels like, the visual looks very different too.
Let's see if it just, we can project maybe. All right. Anything else? Does anyone want to add anything to any of that? Or Lara? No. You have any other questions?
I have a request.
Yes.
Can everyone load their bags up with all of our literature from over there so that we don't have to go home with it? That would be really great. Give out the echo things to your doctors and thanks.
Strangers you meet on the street.
Yeah.
Yes.
I carry my DSM card. You have this. Here you go.
And we actually have a really cool piece of paper that says "My EDS feels like," and we would encourage you to take one of those, write it, and help us share it. For it's EDS Awareness Month right now, so help us raise some awareness.
And nobody has any other questions. Do you guys have anything you want to, wisdom you'd like to impart?
Wisdom.
Oh, you do. Yes. So, can you tell me, are there any new shunts in process right now? I know for draining or syringomyelia versus hydrocephalus.
The only thing that's come out recently has been a device called Reflow, and I mentioned the problems with blocking and small ventricles, and it's a little device which you push on, and it gives a cough and a spurt that goes through the ventricular catheter to try and keep it open. It's we don't know if it's going to work, but we're actually going to be trying it for some people with really small ventricles just to see if it helps things to stay clear longer. It doesn't address the real problems of slit ventricles, but it is something which is trying to keep a catheter free of tissue. There's also a lot of there's things in the works. They're not out there yet, but there are people that are working with. Most of our shunts right now, they have what's called it's a valve that opens and closes. And when it opens, there's no resistance and fluid goes through, and then it closes. They're working on resistance valves, which are a totally different principle. They add resistance. There's different ways that people are trying to make the valves kind of all the time. The only thing that's new also in hydrocephalus is more people are having devices which measure the pressure in your head that you'll be able to read through your skin. So I hope, and we're developing a device also to read the flow of shunts. So we'll be able to, if a person comes in, we should be able to read, or hopefully even over the telephone or telemetrically at some point, to be able to read if your shunt's flowing like it used to, like it did last 3 months, it's still flowing or not. So monitoring of ongoing chronic shunt use is something that's really a hot topic, and it's just taking off now because there's a few pressure sensors that are out.
Thank you. Dr. Luciano, do you know what mild traumatic brain injury, is that known to be associated with an increase in intracranial pressure, do you know? Or, is that generally true? Or I've had people tell me yes and no. I was just wondering.
Does increase in intracranial pressure? Are you saying
if you have traumatic brain injury, I would imagine you'd have some swelling of the brain, which I would imagine would lead to elevated intracranial pressures. Is that the case?
Well, okay. The answer is in the short term, acutely, very often, if it's traumatic enough to be a concussion, loss of consciousness, there's often enough swelling to cause a transient increase in pressure. That may just be hours or a course of a day, and then just fade away. Another part of your question is also in more long term or remotely. We know that there's an increased risk of late deterioration, for example, with buildup of fluid pressure. It's called secondary hydrocephalus, secondary to trauma. And so we know that there's an increased risk of pressure going up in days or weeks, and we're actually studying elderly people who get hydrocephalus, it's called normal pressure hydrocephalus.
Yes.
They're at, we think, it's in the literature, but it's never been verified well, and we're trying to look at the mechanisms. If you've had trauma in your youth, so to speak, do you have a residual increased risk of hydrocephalus and higher pressure when you're in your 60s and 70s? We think the answer is yes, but we really don't know how much and what the mechanisms are. But there is certainly a transient in any major injury.
Well, a couple of years ago, I was trying to write up a proposal with my collaborator because I've done this Chiari diagnosis with high elevated pressures, abnormalities in CSF flow, and I thought this would be a good non-invasive way in a battlefield situation, but I never was able to get the military interested in that. So I just wondered if that was kind of a crackpot idea, or if I just...
No, I think a way of non-invasively measuring ICP, the non-invasive measurement of ICP has got to be one of the things that every neurosurgeon has wished for at night, you know. And there's people looking in the ears and the eyes and with imaging to try and do that. So I think that's a really important thing. Whether it is the actual best proximal measure to index head injury is another matter completely. Probably not. There may be, for head injury, there may be something that's released, like we look at troponin levels and so forth for the heart. You know, there may be release of something that maybe a blood test, if you will, or a CSF test to look for injury. But a pressure test probably would not I'm just guessing, may not be the index thing to measure for that purpose. But the idea of being able to, in the field, so to speak, to measure someone's pressure after a more severe injury, is it going up and continuing? You know, that is a very important thing. Whether we should be putting a ventric to reduce the pressure and drain fluid. So for that purpose, I think it is important. But the trick is in the doing it. You've got ways to do it.
Well, I'll send you my notes on that.
Okay.
You talk about
Thank you. I'm going to guess that music therapy is one of the many modalities that is not covered under insurance. Am I right on that?
Yes, but it actually depends on the state that you're in. There's 6 states where music therapists have licensure within the state. We're working on it in both Maryland and Virginia right now, so hopefully next year we should have a bill in Maryland, where I am. We have submitted a bill the last 2 years, and we're told to revise it each time. It just takes about 3 to 5 years for it to pass. But some insurance companies will cover it as an out-of-network through reimbursement. So, like for example, at our private practice, we have a billing manager who handles those requests and will work individually with patients and families to try to get some level of coverage. But yes, it's the single most frustrating thing right now because there is a lot of benefit, but it's not recognized by all insurance companies yet.
So I want to take one last time to remind everyone that this upcoming week, the DHHS Interagency Task Force on Pain is meeting on Thursday. This is yet another opportunity for us to finally get more things covered. I encourage everybody to go online to regulations.gov, submit your comments, flood them with comments, push them to cover more of these modalities, from music therapy to CBT to Tai Chi. These were all the recommendations that came out in fall, in September. This is now their 3rd meeting, and they're actually going to be voting on those proposed recommendations. Thank you.
Wait for her to finish. And I'm going to just reiterate that that's a very good idea. And if you can include in your comments that if someone is able to have health insurance to cover a form of therapy, then maybe they won't need to visit Dr. Luciano in the future and they can save lots of money.
So naive Brit comment. So what you just said, anyone can do that?
Yeah.
Go on. So it would be we'd love to share that to encourage people. So can you come up to me and give me those details, and we'll get our social media to put that out there and do that. That's great. Thanks.
And then again, to anyone who just walked in, this is like an open forum to just ask whatever you want. You're good? Okay. Anyone? What's your favorite color? Oh, over here.
This might be a little out of the scope, but I was born with cerebral palsy. Do I need to worry more about, I didn't know that you could develop hydrocephalus as an adult. Do I need to worry more about that or a CSF leak because of the brain injury? Because nobody tells you these things.
You know, I don't think so.
Okay.
One of the definitions of cerebral palsy is the injury is already done and healed up, and if you know there's nothing dynamic right now. There's probably additional scarring or anything like that. So if you've grown up and had the cerebral palsy, at this point I don't think. And we have children with cerebral palsy who have hydrocephalus, right, of course. But if you don't have hydrocephalus, I don't think you're at increased risk to get it.
Okay.
No. Those are people primarily with new tumors, or they've had trauma and so forth. There is an elderly group with neuropressure hydrocephalus in their 60s and 70s that develop hydrocephalus, but there's no known relationship with cerebral palsy.
Because I know that the research with adults and cerebral palsy is new, and they're just doing the first study for adults.
May not know.
Wow. Yeah, just now.
Yeah, we're a group that sees a fair amount of adult hydrocephalus and neuropressure hydrocephalus. I would say I don't think that we've noticed any preponderance of people with cerebral palsy.
Okay. Thank you.